Hi, everyone. Good morning, good evening, good afternoon, wherever you are. We are welcoming you to the GICS Congenital Anomalies Group webinar, Club Food Care in Lower Middle Income Country. And with me, my co-moderator is Kokila, Lakhoo from Oxford. And we have speakers, Ms. Judith McCord from March of Dimes, Tijil Rao, racer from India, Professor Norgrove Penny and Professor Vrisha Madhuri from GICS, and Dr. Salimah Walani from MiracleFeet. So shall we start, Judith?
Sure, absolutely. Good morning, good afternoon, good evening, everyone. It's a pleasure to be here today. I wanted to just say a few words about the upcoming International Conference on Birth Defects and Disabilities in the Developing World. As many of you may know, this is a conference that was initiated by March of Dimes in 2001 and started in South Africa. And since that time, we have had a conference every 2 to 3 years. So this year, this will be our 10th conference in a 22-year period. And I'd like to also thank, very importantly, I'd like to thank GICS and Operation Smile for their generous donation to the conference this year. Thank you so much for that. So as you see here along the bottom of this slide, we are in very close partnership on the international conference with the World Health Organization, both the headquarter offices and the regional offices, as well as the U.S. Centers for Disease Control and Prevention and the London School of Hygiene and Tropical Medicine. And our in-country partner this year is the School of Medicine with the Pontificia Universidad de Católica Chile. So they are our in-country partners. We're very, very pleased to be working with them. So as I said, this is a legacy conference. This just gives you a very quick overview of where the conferences have been held in the past, most recently in Sri Lanka. And this is a list also of the various themes that were held or a focus for the conferences in the last several years. So we are very excited to have the conference this year in Santiago, Chile. It is March 1 to 4. And the theme for this year's conference is Accelerating Action for Birth Defects and Disabilities, Surveillance, Prevention, Screening, Management, and Family-Centered Care. We will have a pre-conference workshop on March 1 that was being designed by the Centers for Disease Control and WHO on surveillance. And then throughout the next couple of days, we will have plenary sessions and we will have simultaneous symposium, as well as a fairly robust poster presentation of topics across these areas of surveillance, prevention, screening, management, and family-centered care. So the theme for this year recognizes the continued and critical engagement in surveillance and prevention, and also really trying to move the needle for the management and care of newborns and young infants with birth defects and disabilities. So ICBD is a premier professional development and networking opportunity for stakeholders working in the area of birth defects and disabilities, as well as maternal, newborn, and child health. And as I said, since 2001, we've had this conference about every 2 years and typically convene approximately 300 participants from more than 30 countries. So we're really excited. And even this year, we're already seeing that we have participants from probably about 30 or more countries. And we have right now 200 presenters who have confirmed participation. So the conference provides a unique forum to elevate research findings, share tools and approaches across the areas of focus. And these, again, are from around the world, both low, middle income countries, as well as high income countries. So we really work hard to create a forum for information sharing and knowledge transfer. And we have seen that the conferences really do lead to a more coordinated and effective action around birth defects and disabilities, both globally and at the national level. And typically the people who attend the conference are professionals who work in surveillance, clinical and public health professionals, as well as high-level policy and program personnel from ministries of health, as well as research and non-governmental associations, and also from parent organizations. We are really thrilled to always engage with parent groups and associations to make sure that their voice is at the table and they're helping us shape our agenda and emergent priorities. So if you would like to learn more, oh, I'm sorry, forgive me, there's a slide here about, and I just said this, that we will have over 100 presenters, and right now you can see here some of the countries where these presenters are coming from. So it's a very broad reach geographically. And we have a range of topics and models of respectful care, innovations in surveillance, prevention of birth defects, and surgical management of certain birth defects, which today you will hear more about with this particular webinar. This year, our keynote speaker is Dr. Anshu Banerjee, who is the director of the Department of Maternal, Newborn, Child, and Adolescent Health and Aging at the World Health Organization. So to learn more about the conference and to register, you can go to our website, which is marchofdimes.org. Stroke Our Work ICBD conference, and we welcome you, and our registration remains open, and you can learn more about the conference and all of the details at our website here. So thank you all so much for inviting me to say a few words about ICBD, and we're actually excited to see you all in Santiago in early March. Thanks so much.
Oh yeah, so hello everyone. Good afternoon to all of you in London, and everyone that's in India and everyone's watching. So yeah, I'm Tijil Rao. I'm a Formula 4 racing driver here in India. I've been racing for the past 5 years, and I was born with the condition of clubfoot. I've had around 2 surgeries, corrective surgeries for the clubfoot that I had. One when I was 3 months old, and another when I was 3 years old. So yeah, it's been a very long journey since then. Since a child, I've always been very interested in racing and motorsports and cars altogether. So yeah, I mean, just the passion just kept motivating me to go forward. I had a lot of, because of the corrective surgery, I've had to do a lot of processes in order for me to help in my motorsports and, in achieving whatever I have. So yeah, I mean, it's been a long journey, and I just want to tell everyone over here that if I can do it, you guys can do it too. And I hope I provide some inspiration to all of you that you should not give up. And I hope to become a Formula 1 racing driver someday and represent India and also win a championship for them. And yeah, I'm guessing, I'm hoping all of you are doing well. And thank you so much for inviting me to this webinar and have a talk with all of you. Thank you so much.
Thank you, Tijil. We'll have some questions to you also at the end of the session. Okay? Professor Norgrove Penny.
Are you able to see the screen? I hope that's acceptable now. Just takes me a moment to get set up.
Now we can see it. Yes, it looks good.
See and hear, I hope. Well, thank you for your introduction and and greetings from Canada. I would like to organize this talk in 3 sections. The story of the clubfoot treatment revolution, a global clubfoot initiative using a public health approach, and can we do the same for other structural birth defects? I'm going to just try and minimize some things here. It looks like the screen is blocked a little bit. Just let me see if I can get this out of the way. I'm a pediatric orthopedic surgeon. In mid-career, I and my family lived for 6 years in Uganda, helping establish a children's orthopedic rehabilitation project. I was the only pediatric orthopedic surgeon in the country of 25 million people, and the only one outreaching the rural population. The burden of untreated orthopedic disability in children was enormous. Among them were many children with congenital limb impairments. And our work also helped identify many children with cleft lip and palate and other untreated congenital deformities. Congenital talipes equinovarus, or clubfoot, is the most common birth defect causing locomotor impairment in the world. Everywhere I went, there were many children with these sorts of untreated deformities. And I found myself performing more than 150 operations every year on children with clubfoot deformity. These are highly complex, difficult, and time-consuming procedures that I found I could not teach to non-specialists, it was obvious we were barely touching the tip of the iceberg. The Ponseti method has revolutionized clubfoot care. It began while I was in Uganda with the publication of Dr. Ponseti's book and the long-term follow-up report of Cooper and Dietz. Among the very early adopters who visited Dr. Ponseti to learn his technique was Shafiq Pirani, a fellow Canadian. Shafiq had visited me in Uganda and seen the huge volume of children I was treating surgically, and we had strategized on how we could meet the need. The Ponseti method is a very exacting and specific method of serial manipulation and casting of the foot, followed by a percutaneous tenotomy of the Achilles tendon, which can be done under local anesthesia, and a maintenance phase of bracing. It produces superior results to any surgical approach. In Uganda, out of necessity, we happened to jump on the method very early, before it was adopted as the gold standard in the developed world. By pure serendipity, therefore, we were able to put together a local team on the ground with Shafiq Pirani visiting and bringing in resources. And we developed the Uganda Clubfoot Project in collaboration with our Ugandan colleagues. This was a comprehensive capacity building project and became quickly successful. We were able to prove that the method worked in a low resource African scenario and was easy, effective, efficient, and economical. The Uganda Clubfoot and subsequent Uganda Sustainable Clubfoot Care projects were capacity building projects which included curriculum development, curriculum and training saturation, and task shifting. Public health principles were implemented, including a countrywide dissemination to the districts and the involvement of community-based rehabilitation. In this way, a national plan was implemented, the first of its kind that we were aware of globally. The project was collaborative amongst the Ministry of Health, the Department of Orthopedic Surgery at the National Referral Hospital, Makerere University training institutions, not-for-profit hospitals and rehabilitation centers, local non-governmental organizations dealing with children and with disability, and community rehabilitation projects. Training, logistical, and financial support came from overseas through NGOs and government grants. What were the ingredients that made this project so successful? Firstly, the curriculum. The curriculum we developed in the first Uganda Clubfoot project in 1999 was based on Dr. Ponseti's book and has stood the test of time as a gold standard curriculum. Dr. Lynn Staley at Global Help, a not-for-profit publisher of freely downloadable books and curriculum for practitioners in low resource environments, was an early advocate and printed the Ponseti Red Book. This book has been translated into many languages and has been used powerfully around the world, not just in Africa. We implemented our program by training orthopedic officers, a cadre of non-physician clinical providers that were the backbone of orthopedic care in the country, since there were so few orthopedic surgeons. And we proved we could task shift expert Ponseti clubfoot care to non-physician providers, not just as practitioners, but as trainers, and achieve results on a par with specialists. Ugandan co-worker Michael Steenbeck developed a brace made with local materials at insignificant cost. To meet the need of the majority of children unable to access care, we had to become champions of a comprehensive public health approach. In order to do so, we needed to change our perspective to think to get treatment out of the institutions in which we worked and into the community. We had to think of how to get care to the child instead of the child to our care. Our guiding mission statement became, the poorest child in the most remote village. What does it take to reach that child and treat that child? How do we reach every child? This principle is at the core of a public health approach. We were able to source local champions from amongst clinical leaders, academia, and the Ministry of Health, including the Vice President of the country. The support from ministry enabled clubfoot care to be integrated into the National Health Plan. The country was mapped and clubfoot care centers were established in almost all the administrative districts of Uganda, staffed by trained orthopedic officers, distributing the care outside the national specialist centers. Posters were developed in many of the indigenous languages to raise awareness in the communities and provide information on the closest treatment site. The curriculum was then adapted into a booklet that became a standard curriculum in all health training institutions in the country to raise awareness about early identification and treatment. The booklet was color-coded to highlight specific relevance to various healthcare providers such as midwives, nurses, and frontline health workers, as well as orthopedic practitioners. The process became one of converting a vertical program of subspecialist clinical and surgical care into a horizontal program encompassing the whole health system and the community. We took the training to neighboring countries and adopted it, and within a decade, the methodology had spread around the world. In 2009, some of the early adopting NGOs got together to form the Global Clubfoot Initiative, established around the goals of awareness, advocacy, training, service delivery, and the establishment of national plans. Collaboration among 60 or more countries has allowed for the collection of so-called big data. We have seen the rise of supporting non-governmental organizations around the globe. It has truly been a revolution. When the All India National Clubfoot Curriculum and statewide strategy was written, the Uganda Clubfoot Manual and Curriculum was adapted. The Global Clubfoot Initiative developed the Africa Clubfoot Training Course, which is now the standard training course for Africa. And the curriculum is an expansion of the Uganda Clubfoot curriculum. This course has now been adapted in the United Kingdom and in Norway for training their clubfoot practitioners. Then in 2015, there came the game changers in the world of global surgery, including the Lancet Commission on Global Surgery and the disease control priorities of the World Bank. 40 surgical conditions were deemed essential and of highest priority. And amongst these was correction of congenital deformities, including clubfoot. And so the question now is, can we do the same for other birth impairments? What about converting the vertical program of clubfoot into a horizontal program, including all structural birth defects and perhaps other childhood diseases? Can we develop a pilot program somewhere? We can learn from the Uganda Clubfoot template as to how to set up a comprehensive horizontal program, incorporating all the pediatric subspecialties treating structural birth defects. The RBSK program of the National Health Mission in India could possibly be used as our template for developing national plans for structural birth defects. This program trains frontline health workers called ASHAs in all the states of India to identify children who have birth defects as well as other childhood diseases and refer them to the appropriate treatment facilities. This is their virtual curriculum on the examination of newborns for structural birth defects. I have highlighted the clubfoot photograph. With partners in Tanzania, including the Ministry of Health, we have done some work to develop a toolkit for awareness and early intervention for structural birth defects, consisting of laminated flip charts for use on the front lines, backed up by a fact sheet for program administrators and a manual for field workers. We presented this particular project at the last GICS meeting in Johannesburg. What is the way forward for those of us in the Global Initiative for Children's Surgery? I believe we are well positioned to be world leaders. Amongst all structural birth, almost all structural birth impairments require surgery, and we are the specialists. We now have specialty collaboration within the organization. We can share our experience. The South-South dialogue we bring is vital to solve the problems of lower resourced environments. The needed ingredients would be to identify national champions, develop a standardized curriculum, champion a public health approach, map the health systems of the country, collaborate with NGOs, and work with our ministries of health to develop national plans. The way forward to everything we do is collaboration. GICS provides a perfect opportunity to encourage and foster that collaboration, and I hope everyone here gains value and learning from the experience of their colleagues. Thank you for the privilege of giving the talk. I wish you all of you every success as you take care of the children you see and treat.
Thank you very much, Penny, for such a wonderful talk about the clubfoot. We'll have, I'm sure, many questions to you after the session. Vrisha, now your turn.
Good morning and good evening. Would you play my video, please? The recorded video.
Yeah, let me play it for you.
Algorithm for clubfoot management. The clubfoot deformity has several components. There's equinus, cavus, heel varus, and forefoot reduction, which are the main deformities. In addition, there's a calcaneopedal block rotation, and in older children, internal tibial torsion is also seen. An important component of the deformity is the weakness of the peronei, and there is a lack of foot abduction when you stroke the outer border of the foot. This is an important component of deformity because important component of deformity because the lack of peroneal action leads to relapse. So a classical clubfoot deformity presents at birth and can be seen affecting mainly the foot. They can be polydactyly associated with this. Atypical clubfoot presents after the few plasters have been applied, and there is a swelling of the foot, a gross cavus with the marked creases and equinus. Hemimelias show equinovarus along with decrease in size of the tibia and the number of digits. Calcaneum valgus is something which can also be mistaken. Slightly older children, anterolateral bowing due to or congenital pseudarthrosis or osteogenesis imperfecta, up to glypotics, vertical talus, and in children, cerebral palsy, spina bifida with deficits, tibial hemimelias in older children, trauma and osteomyelitis due to scarring and physeal injuries, and post-polio residual paralysis. All are known differential diagnoses, and they should be differentiated from congenital talipes equinovarus. There are associated conditions with clubfoot which should be looked for. Otherwise, these can be missed and diagnosed only later when they present with different symptoms such as developmental delay or waddling gait. These are DDH, some genetic conditions such as Down syndrome, neural tube defects, trisomy 13 and 18, congenital vertical talus and other congenital abnormalities, muscular dystrophy, and in rare cases, cardiac defects can also be associated with clubfoot. So it is good when the child is seen for the first time for these to be diagnosed and managed. So treatment for the clubfoot is almost always conservative, and mostly now the Ponseti technique is followed. And in some parts of the world, the Bensahel technique, which is a French method of physiotherapy, is also followed. So manipulation is done using talus as a fulcrum, supination and external rotation to achieve correction, followed by dorsiflexion and then the abounding cast. So the very first step for doing this correction is the elevation of the first metatarsal to correct the cavus, then gradual external rotation till you are able to achieve about 70 degrees of external rotation. And this is followed by dorsiflexion once the external rotation is achieved. And if this is achieved, then you go on to do a plaster cast. If this is not achieved, then once the foot comes to 90 degrees and there's lack of progression, you would then in that case do a tenotomy. So plaster cast is put for 3 weeks, and in the older children, the cast can be repeated twice. It's very important throughout this manipulation technique that a serial measurement of the score is done to see whether the deformity is correcting or not. The two commonly used ones are the Pirani and the Diamaglio ones. If you find that the score is not improving in 2 subsequent casts, then you have to consider moving on to another method of treatment. So the management principles for conservative technique then are manipulation starting at the very earliest possible, watching the improvement in correction with every plaster cast and manipulation, and when the improvement stops, either tenotomy or other surgical procedures, and slippage of cast and the other complications should be avoided and monitored, usually by putting bi-weekly or weekly casts. This is very much decreased. This complication is very much decreased. So to summarize, in the conservative, when we treat conservatively, we should pay special attention to avoid complications. It is important to accurately score and assess the progress. And it is important to identify when the clubfoot become resistant and we are not getting any improvement, and then go on to tenotomy or to refer for possible operative intervention. And if the correction is achieved, then the next step is bracing. So why bracing? This is because the dorsiflexors and everters are weak, and even when you have achieved the correction, they continue to be lax and are weaker, and therefore they have to be maintained in a mildly dorsiflex and everted position or externally rotated position. Previously, the brace used was called Dennis-Brown splint. Now a generic term, foot abduction brace, is used, and it is required for 2 to 4 years and is worn full time for the first 3 months and followed that about 14 hours a day for the subsequent period. Prerequisites for bracing are that we should have a completely corrected clubfoot, and we should have at least about 30 degrees of dorsiflexion in the foot to put the child in the brace. So usually the brace has about 70 degrees of abduction, foot abducted on the affected side, 30 to 40 on the normal side. And the bar should be wide enough to be beyond the shoulder width. So that would make it be comfortable for the child. And just to show you that this technique really works well is a 6-year follow-up. You can see that while the power of the gastrosoleus is maintained, there is full correction in this child, and the child is able to sit and squat. So sometimes the bracing is not well tolerated, and this is because it's uncomfortable. The lack of movement sometimes makes it uncomfortable for children. It's just a brace that we have designed, which allows for alternating knee movement and the foot movement. And it also allows the child to crawl while using the brace with alternating leg movement. And this is what we found was more easily tolerated by the family members. We also had the ability, when using this brace, to see how often the child was wearing the brace by using a sensor. And here you can see that the child in a 24-hour period has taken it only off twice for less than 1 hour period on both the time. In the next patient, here we find that the child was not wearing the brace, and they finally admitted it to it. And there was a gap of nearly 14-15 hours when the child was not wearing the brace. Child was wearing the brace when the father returned in the morning, and then it was going off again in the morning. You can see the difference in the correction in the patient 1, where the brace was on full time, the dorsiflexion is still good, and the foot is well corrected, where in the patient 2, it is not corrected. This just goes to show that in the initial phase, you need to wear at least about more than 20 hours brace for the first 3 months. But we found that in our groups, anybody who used the brace for more than 16 hours a day didn't do well, and there was no recurrence. So to recap, bracing is key to success of this treatment. It can only be done after complete correction. It requires a foot abduction brace and feet placed in external rotation. Dynamic bracing is superior, and lack of compliance is related to discomfort, and compliance is therefore important if you want the bracing to work. So what happens to children who do not respond? That is, they are resistant, that is, the foot doesn't correct completely, or there is a relapse, that is, the foot corrected and then relapse, and in the younger age group, that is up to 4 years of age. So if you find that a repeat casting still does not give us a good result, then usually a soft tissue release is done. It can be done a la carte. That is, if only less than 2 deformities are present, and if 2 or more deformities are present, usually we choose the modified posteromedial release. There are other forms of releases also described, which can be used for very rigid club feet, but usually not indicated in the milder club foot. The radiographs are useful when you are dealing with such cases, because when empty heel is in doubt, you can confirm by whether the equinus is corrected or not. And we can also assess the bony deformities. In resistant feet, it helps to rule out congenital or acquired tarsal collision, and also assesses the outcome and complications and follow-up. So this is just to show you how we do it. Here you can see when we measure the tibiocalcaneal angle, it is showing a good correction of 22 degrees dorsiflexion. So this is a well-corrected foot in cast. Whereas on this side, you can actually see that the talus and calcaneum are pointing down, and there is actually a rocker bottom foot deformity on the right side. There are other things that you can look at in the older children, where you can see there is a talocalcaneal collision, and there is a varus deformity and forefoot adduction deformity. By drawing the appropriate angles, the degrees can be checked. In this child, there is a very severe supination deformity of the first metatarsal, and this allows us to choose the kind of treatment that we do. So what are the causes for relapse? Relapse usually occurs if we did not obtain the complete correction in the beginning, and it also occurs if the foot is corrected well, clinically and radiologically, and then if you make it worse, then it becomes worse, then usually it's a neurological cause. So object of any surgery or conservative treatment is to obtain a full and lasting correction. And for this, it's better that if we are going to do a surgical procedure, we should release any deformity component that is there to restore the tarsal bones to the normal position. So types of operations that are required, and this hasn't changed all that much in the past, is either soft tissue procedures or a combined soft tissue and bony operation, and bony operations only. So mostly it's the soft tissue procedures or a combination soft tissue and bony procedure in the older children is done. The major problem with the surgical releases that you can land up with getting an overcorrection. Usually when you use very major subtalar releases and tibia transfers, which are very much lateralized. So these tend to cause overcorrection. So other procedures, bony procedures are decancellation operations, tendon transfer of Gaucher or the tibia lateralization is commonly used, and different osteotomies of the tarsal bone, the cuboid, the calcaneum, and the metatarsals or the midfoot osteotomies. And for a skeletally mature child, the deformities can be corrected lastingly by using a triple arthrodesis. Some methods of gradual corrections are also used. These can be for using soft tissue distraction, either by using a Joshi clubfoot fixator, which is commonly used in India, or Elizaro. These are non-invasive, they lengthen rather than shorten. And they have been known to cause sometimes malalignment of the joint. This is the kind of frame that is used when you use this. And this, just to give an example, this child has very, very bad scarring on the medial side of the foot and quite significant deformity. Equinocavovarus, all components were there. And using the Elizaro correction, you can get actually very good correction without making the scarring worse. So to recap, to choose the procedure, we based on radiographic and clinical assessment, and this includes the age. So before the bony deformities occur, you can choose the soft tissue procedures. Once the bony deformities have occurred, then you choose the bony procedures. And of course, things like size of the foot and stiffness are involved in the making the determination of what you're going to do. With significant scarring and severe deformities, frames will avoid soft tissue complications. Neurological deficits always require AFO. So thank you very much.
Thank you, Vrisha, for a wonderful presentation. We have, for all the participants and the panelists, there are some questions put in the chat box. If you can answer in the chat box. Now, the last presentation from Dr. Salimah Walani from MiracleFeet. Salimah.
Hi, everyone. I am Salimah Walani. I'm Global Policy and Advocacy Advisor for MiracleFeet, which actually is one of the co-hosts of this webinar. I am very appreciative for GICS to be doing all the management and getting all the speakers aligned for us. It is my pleasure to speak on behalf of MiracleFeet, which is actually an organization that is very new. It is a not-for-profit organization that is based in North Carolina in the US, but has had a major influence on the care of clubfoot and also its advancement around the world. We've taken the work that my colleague, Dr. Penny, spoke about in Uganda, and we've made it into a model that can be used for other birth defects and also for expansion of advocacy efforts for newborns and children. So I would like to share with you today how MiracleFeet has done this work and how we can take it to the next level. So someone in the chat asked how many babies are born with clubfoot around the world. And it is very difficult. As you know, the surveillance of birth defects is very sketchy. We don't have a lot of data, particularly in LMICs of Asia and Africa. There are hardly any surveillance programs measuring not only clubfoot, but any other birth defects. So based on what we know and what is available, we and all my colleagues at Global Clubfoot Initiative and other organizations will agree that we think that about 200,000 babies are born with clubfoot every year. And like with all other birth defects, most of these births, the majority, like 90% of these births, are actually occurring in low and middle income countries. And it is so unfortunate that even though there is this method, there is so much knowledge already that has been tested, there is evidence-based technique available in the Ponseti method, 85% of the babies born with clubfoot do not receive the care they need. So that's where MiracleFeet comes in. And what is our goal? Well, if we do it all right, if all of us do it right, every baby born with clubfoot anywhere in the world should get the timely evidence-based treatment for clubfoot without hardship. And we can do this by raising awareness, improving political will, influencing policy and legislation, so that financing can be allocated for clubfoot treatment, and training and supplies are needed to improve access to care. So if that's the goal, let's see how MiracleFeet has been doing it. Well, we have in our history of almost 13 years or so, worked through improving access through local partnerships. We believe that there's no need to go ahead and establish new clinics in each country where we work. Instead, we should identify local partners, get into agreements with them, and give them the right resources and supplies, technical as well as actual material supplies, and build capacity through training. And then, do advocacy at the national level as well as global level to increase the awareness and policy action for clubfoot. So let me first talk about how we are improving access through partnerships. So at present, MiracleFeet has partnership-based clubfoot programs in over 30 countries, and they're all in low and middle income countries of the Americas, Asia, Africa, and the Middle East. Since our inception in 2011, we have grown immensely. As of this year, 73,000 children have been enrolled in clubfoot treatment programs that we support through 300 clinics around the world. Some countries shown here in yellow are actually countries where we're reaching over 50% of babies born with clubfoot. MiracleFeet's model of working through partners rather than establishing new clinics is working well. We have calculated on average that it takes approximately $500 to treat each child born with clubfoot. And clubfoot treatment prevents lifelong disability, so the return on investment is very, very high in quantitative and qualitative terms. The second way we have been doing this is through, once we've identified a clinic and have established an agreement with a local partner, we ensure that our supported clinics have the necessary supplies and technology to provide quality clubfoot care. In many LMICs, and I've seen it in Pakistan and during my visit in Uganda, there is, and other places, there's shortage of plaster, braces, and shoes. And MiracleFeet has been addressing these challenges by targeted efforts. So this is the MiracleFeet brace. I don't know if you can see it, but innovation has been critical. And as we scaled, we created tools that allowed us to expand without losing control over quality or costs. There's a worldwide shortage of braces. And we created this brace of our own in partnership with Stanford University's Design for Extreme Affordability program. We wanted to develop a brace that was replicable, can be mass-produced and distributed in LMICs. So MiracleFeet produces this brace for $20, which is less than the cost of the brace that is currently used in the US. And our design has been developed and improved with feedback from families and providers. Today, MiracleFeet brace is used in 20 countries around the world. The other innovation that we did is we rolled out a cutting-edge monitoring and evaluation system thanks to funding from Google. Our data platform is used in over 300 clinics worldwide at this time, and patient information is gathered at the point of treatment, which allows us to monitor performance and determine how we manage our workflow, where do we allocate more training and resources. Then the next step, like I said, is training. So you heard from our colleagues that the method is well known. It can be done. Then what we need is to train a lot of healthcare providers everywhere in the world to do this right. And therefore, it is very important to make sure that they have adequate training in Ponseti method and are given the support and supervision they need. So MiracleFeet has been actively involved in training programs to improve care. We use the Africa Clubfoot training curriculum that was mentioned earlier. And in that, we've been conducting the basic and advanced training, the Train the Trainer course. And also training is available through e-learning platforms. What a success we had recently through collaboration with Pan American Health Organization. And just a couple of months ago, an online course was launched. It is not a course that actually is a specific training in clubfoot care, but it definitely is a great tool for healthcare providers to understand what is clubfoot and how they can at least identify it and refer. Early detection and referral in clubfoot care is very, very essential. Then, so I talked about capacity building and supplies and local partnerships. But one other thing, the reason why MiracleFeet is a movement, a global movement for clubfoot, is because awareness raising and national advocacy in the countries we work in is where our focus is going now. We have been reaching out to large organizations, not just those that work only in clubfoot or only in birth defects, but those that work in maternal and newborn health, particularly to make sure that clubfoot remains a relevant issue in many of the policies for newborn health. So the way we are doing this, is I have this way of thinking, and I've been saying we need to shine the light first on the burden of clubfoot. Is it a small issue or is it a big issue? Then once we've determined and start to talk about how important this small defect is, if it is not corrected, what does it do to people's lives, individuals and the society and the family and the country? So we need to do a lot of advancement in the area of awareness. Then there are many global movements. One of them is the birth defects movement, and we need to ride the wave and develop the issue of clubfoot through those movements. We need to again spread the word about clubfoot using social media and other traditional media. Then the most important segment in global advocacy for clubfoot is the parent organizations and the civil society organizations. We need to engage with them, let them tell their story, just the way Tijil today told his story about his experience with clubfoot. The other movement, if we may say, is the Sustainable Global Development Goals. And under goal number 3, universal healthcare coverage is a key. Leaving no one behind. Are we going to leave the babies born with clubfoot behind? Are we going to let them live a life of disability? I think that universal healthcare coverage concept is a very good tool for advocacy for clubfoot. Engaging with media. This is an example of the power of media. New York Times had a series of articles which were actually initiated by MiracleFeet's then CEO to enable awareness raising. Other measures, other avenues we have, Twitter, LinkedIn, whatever we can use, we should use to advance the issue of clubfoot. Conferences like the one that my colleague Judith presented, the ICBD conference, and other international maternal newborn child health conferences happening, the role of Global Clubfoot Initiative in advancing the issue of clubfoot is all coming together. We are actually going to be presenting and hope to see a lot of you at the ICBD. And then we are a sponsor of International Newborn Health Conference. Our president, Ms. Daphne Sorensen, is going to be at the IMNH conference, and we are going to be present at ICBD to answer any questions and to also help establish any collaborations with regards to Clubfoot. Lastly, let's not forget the World Birth Defects Day. I don't know how many of the 66 or 100 participants of today's webinar are engaged with World Birth Defects Day. It happens on March 3rd every year. And in fact, this is going to be the second day of the conference, second full day of the conference in Chile. So we will all be there. And I invite you to become a partner of World Birth Defects Day through this website. Join in to the efforts. There are tools and guidelines available. We should all be talking about Clubfoot on the World Birth Defects Day, as well as on World Clubfoot Day, as well as on any other day. Regardless of the platform we use for advocating for Clubfoot, I think three key messages we can repeatedly talk about is that it is a common birth defect. It is not just happening somewhere remotely in a village. It's affecting a lot of babies. It's a newborn health issue, because by early detection and referral and treatment, we can prevent childhood disability. There is a cost-effective and scalable treatment available, and we can align this concept with universal health coverage. We should also significantly emphasize that if not treated, Clubfoot causes significant disability and cost to individual, family, and society. In the end, I want to leave you with the story of baby Rez, who came into our clinic in Uganda in 2020. He was 3 weeks old, and he was the 50,000th child to be enrolled in treatment. 3 weeks is a very good time to bring a child into treatment. They are still a newborn, and we can do so much if we start treatment so early. You can see him when he was 6 months old. Actually, 6 months later, in March 2021, he had 4 casts and a tenotomy in the first 2 months, and he was moved on to wearing a brace. And lastly, at the age of 18 months, with corrected feet during one of his brace checks, getting a new, larger brace. Treating this condition at birth transforms the trajectory of a young life forever. Although we cannot eradicate a birth defect, we don't know the cause of Clubfoot, but we can prevent a painful lifelong disability by making it accessible, making the care accessible to all babies. And thank you so much. I really appreciate that I had a chance to speak with you.
Thank you very much, Salimah, for giving an insight into this Clubfoot management. Kokila, if you can start the question answer session.
All right. Thank you very much to the panelists. I think this is a really exciting topic, and a lot of the questions have been answered by the following speakers. But I'll just start off and I'll go according to as the questions were being asked. The first question is to Norgrove Penny as to what are the challenges in treating Clubfoot with patients with spina bifida, especially neuropathic foot?
Yes, what we've found is that the technique is applicable to children with myelodysplasia, arthrogryposis, all the other genetic and congenital issues that can cause talipes equinovarus. I mean, the Ponseti method that we've talked about, we're mainly talking about idiopathic club feet and isolated deformity, but this can certainly be used in all the other conditions as well. There are some technical challenges. For instance, in arthrogryposis, feet can be more resistant, take more casts, more failures of the Ponseti technique where we have to intervene with some surgical intervention. But in myelodysplasia, the feet can correct really quite dramatically well but one has to be very careful about the casting process so as not to cause pressure sores. And at the end of the day, procedures to rebalance the foot by tendon transfers, because this is a neurologic condition with, asymmetric neurologic effects on the foot. So the technique is very adaptable to those, but with additional complex considerations, let's say. In the idiopathic clubfoot, the Ponseti method, if we can get to these babies early, within the first 3 months, as we've shown, or 3 weeks, as we've shown, is perfect. But we've shown we can correct using the Ponseti technique in much, much older age groups and avoid major surgery in the vast majority. The success rate of the procedure is about 93% or so. There's only that very small percent that needs to go on and have other procedures done. So it's a very effective technique, but it's very precise. It has to be taught extremely well. And that's getting into the training that Salimah Walani's talked about. We have to train and retrain to make sure that people do it exactly correctly and somehow distribute it right out to the population. I hope that answers the question.
Yes, I think you have. And also you've answered one of the questions about what is the appropriate age. So thank you very much. I'm going to move the second question.
Kokila, may I just, could I just add something to this? Because there are some challenges that are there, which precludes some of the steps that we use in the Ponseti. And that is mostly if there is a neuropathic clubfoot, in that case, the L5-S1 is gone. And then if you do a tenotomy at a later age, they will develop a calcaneus foot. I think so that part has to be understood. And secondly, the plaster casting has to be very, very careful because they have no sensation sometimes and they're likely to get more pressure sores. So those things. And thirdly, you cannot put the brace that is usually used. They need AFOs. So I think those are the 3 points which should be highlighted.
All right. Thank you, Vrisha. So the next question is to Judith, and Salimah, you can add to it. But there's been many, many questions about how can we bring this to our country, especially people from Eastern Europe and the ex-Russian ruled countries where there isn't these programs. How can you bring these programs in? So I'll start off with Judith, and then Salimah, you can follow on from Judith's answer.
Yeah, and my answer is really from the broad stroke of opportunities where groups like GICS are able to share the process, the intervention, train other practitioners, as you said, Dr. Penny, the need for specialists. So we can do a lot, even at ICBD, where you're able to advocate and share the story, share the intervention, and start really mobilizing investment for other countries to, hoping that other countries will see this as a priority. So it's really advocating, sharing resources and sharing lessons learned and approaches. And then I'll leave it to Salimah to talk more about the kind of the mechanics of all of that, because I think that's what you all have been doing at GICS.
Well, MiracleFeet is constantly growing. We are improving care in over 32 countries right now. And if there is a low or middle income country with a partner who is willing to work with us or is interested, we could definitely assess, and if necessary, if there is enough need and possibility, we could actually look into the possibility of collaboration. There are also other ways. There are a lot of training programs through Global Clubfoot Initiative, also through MiracleFeet. If there is a training happening near you, you could probably join the training, and then we could actually be supporting you. So there are many possibilities. We'll have to assess the need and then bring a program to a country where it is possibly needed. Norgrove wants to add, I think.
Oh, just an interesting comment that I've noticed. I mean, these sort of national plans have developed in lower and middle income countries. The lower income country, the better the implementation, the more collaboration from Ministry of Health, from World Health, That's very interesting, because in more developed countries, I know of no public health approach to clubfoot or other birth defects. They're all institution-based. You know, we have a powerful university here. We've got a powerful children's hospital there. Just go there and get treatment. And the word gets spread somehow around that that's where you go. I live in the most socialized healthcare system on planet Earth in Canada. We have zero private medicine here. It's all public. You would think we could have a national plan in clubfoot. No, we don't. We do not have it integrated into a national policy. So I think this is a really interesting area where countries in the lower and middle income countries can actually teach us a better way of doing things. And this whole concept of getting out of the institution and into the public domain. So that was brought up a lot in what Salimah said as well. We need civil society involved, the parents involved. They've become the most powerful agent of change in clubfoot. Way more powerful, I think, than what we've done in our research and treatment centers, the parents and the social media. And I've just thought this is a very interesting dynamic that we've seen. So probably the countries of Eastern Europe are somewhere in the middle. There's lots of need to get out to perhaps the remote and rural communities, but they're sophisticated healthcare systems, so they don't have the same need that a country like Uganda or Pakistan need in order to reach their population.
I think we have a classical example of our recent pandemic where the low and middle income countries have managed public health. They have public health, so it's done really well compared to the high income countries that don't have public health. So they went for the high end treatment rather than the prevention, which was practiced by low and middle income countries. So, we're seeing this on and on in every walk of life, where high income countries go for the high kill without looking at public health and prevention. Just to move on, there was a question about how many low and middle income countries have clubfoot been included in national or state fund insurance policies? I think I'll ask that to Salimah.
I don't think we have a count of that. We are trying, for example, I know Uganda is very active. We have actually through MiracleFeet, an initiative in the Philippines, Madagascar, and Tanzania. We are trying to include and integrate clubfoot into national health programs, but I don't think we have the exact answer as to how many countries have it. One suggestion I have for many national leaders is to try to align clubfoot care with newborn health action plans of each country. There is the Every Newborn Action Plan guideline from the WHO and UNICEF, and many ministries of health who are developing programs are looking into it. If you have a way to influence your newborn health and maternal child health departments to integrate clubfoot in those plans, that would be a very successful thing to do at a country level.
Thank you, Salimah. Question for Vrisha regarding braces. How accessible are they to families, and especially families in low and middle income country, and how affordable are they?
I think in India, at least the braces are made at every O&P&O workshop. Sometimes they are not very high quality because they're all made locally. So these are very much available, and the cost of the braces are not very high. I think in 2010, when Dr. Penny and had visited us in Vellore, we actually conducted a very big workshop for making braces, where the doctors also learned how to make braces, which helped us to understand what are the problems with the shoes. And we taught it to about 10 different hospitals, P&O workshops. And that, I think now actually finding a brace is not a problem at all in India. And in fact, we designed our own brace based on, after listening to them and with our experience, we designed a brace which had sensors for us to be able to research further. And we designed a brace which had mobility, and all, by the way, still costing less than $20. It wasn't more than $20, less than that. So that was good. But just the previous question that you asked, in India, the public health system, that is the insurance systems, Both at the RBSK provides money for any clubfoot child identified to be treated. In addition to that, there is every state insurance has got money provided for the clubfoot child to be treated. So there is outside of the government hospitals, the money for the clubfoot child is available in all systems.
Thanks, Vrisha. Question to, I think I'll take it back to Salimah, and I would ask the other panelists to answer as well about nurse-led training, and also how do we take the training into the community, because in LMIC, it's very difficult for parents to come into centers for their training, for their treatments. So with poverty and lack of access in rural areas, how can we take this to the doorstep?
Well, I think Norgrove can answer this a lot better than I can. So I'll just say one sentence that nurses are a great resource, and also not only nurses, but midwives in remote communities of the world. I know GICS also is into task transference, and also Norgrove mentioned that this treatment doesn't need to be always done by orthopedic surgeons or medical doctors. Therefore, if we could actually reach out to the healthcare providers in communities, even at the lowest cadre, birth attendants, to at least, if nothing, recognize clubfoot and then refer them, that would be best. But how do we get the training to all the people who need it? I will leave this question with
Norgrove?
Well, that booklet that I talked about in my talk in Uganda that we tried what's called curriculum saturation. That is that every health discipline in the country, no matter what level, and no matter what specialty, learned something about clubfoot, so they were aware of the condition and aware of how to refer it. And a big target of that was our nursing colleagues, and especially early childhood development type nursing situations, public health centers, vaccination points, where we could, and the main role nurses had, I think, was in early identification and creating awareness with the families, and then also acting like counselors of the families as they go through the process. The idea of actually training nurses to do the technique is more problematic because it is actually quite tricky. You need some sort of a technical background in this, so that training an orthopedic officer, a physiotherapist, or even an orthotist, prosthetist, yes, we could do, because they're so used to hands-on with little feet. So we could actually train them how to do the technique. It would be much more problematic for nurse to teach nurses that in a broad spectrum way. But to be part of the team, especially at the public health interface, absolutely. And so we really tried within Uganda to train nurses at that level in their training programs, midwives, etc., about clubfoot and how the system worked.
Thanks, Norgrove. The other question was, or a statement was about the braces and their availability in every country, because Daphne has mentioned that the braces are also part of the WHO's priority list of 80 devices. So just for people to be aware of that. The question I have is to Norgrove. Norgrove, did you have resistance when you started this process by very specialist orthopedic surgeons who felt that the operation was the best way to go? And there are still people that believe that. And how, if you give us a little bit of your story of how you convinced the world that this is the right thing to do.
It's a very interesting and story, actually. When I was in Uganda in those years, we were considered the 5th from the bottom in terms of human development. And so there was this huge need, and the orthopedic surgeons recognized that and said, wow, we'd love to get that dissipated out because we can't cope with it. And we had 100% cooperation. And with the government, that was recognized. But the higher up the scale you go and the more technical people you get, the harder the convincing. So the uniqueness of the Uganda Clubfoot project is we implemented it at a unique time in history. It's not even, the country's much more sophisticated now. We had no pushback at the professional level. In fact, 100% support. But it took a decade, fully 10 years, before it was accepted in United States, Canada, Europe, and the developed countries. Surgeons did not want to let go of their surgeries and all of the history that they had in surgery. And the reason I even got onto this platform, shall we say, as an expert, I was then invited to Dr. Ponsetti's workshops. He was starting to train it, because nobody in the world had the experience I had teaching people how to do the clubfoot, the Ponsetti technique. And here I was teaching all these North American experts, and they were always rebutting me, saying, but no, it was so difficult for 10 years to convince our orthopedic specialists that this was a good technique. Now it's universal. Now it's well understood. And it was data that brought that out. And the early data all came from the developing world that convinced the developed world that they were wrong. And what happened was parents picked up on this. When I say the internet and parents were important, parents would go to their doctors in the United States or Canada and be told, you've got a little baby, you've got a clubfoot, we're going to disassemble this foot surgically and put it back together again. And they would go home shell-shocked, and they would go on the early days of the internet and find there are these people in Uganda correcting this thing without surgery. And they got connected to Dr. Ponsetti's website, and they abandoned their specialist doctors in the United States especially, and just flew to Iowa. And it so embarrassed the surgeons I was training. They were there because they had been embarrassed by patients criticizing them and saying, you are not up to date. They can do this in Uganda. Now they're doing it in India, and you're not doing it here. So that the whole intersection of the media, the social media that has been talked about, and parents is what I believe actually drove the revolution in clubfoot care in North America. And we were just fortunate in the developing world to have the resources, the circumstances to show it worked even in our circumstance, so it could work anywhere.
Thanks, Norgrove. I think the question to the panelists, in that when you look at clubfoot and you look at cleft lip and palate and you look at hydrocephalus, you can see there's lots of advocacy for it, from the public, from the parents, from the kind of care providers, because they're all visible. What happens to a lot of things that we as pediatric surgeons do, which are not visible, but correctable and can give you, normal lives, such as the bowel obstructions or the anorectal malformations or things that are hidden in the abdomen? How do we model this and apply it to the way it has been done for the visible abnormalities? I think we can start with Norgrove, since you are on the main screen.
I'm quite passionate about this subject, as you see in my talk. I felt very badly that in Uganda, we had this really great program for identifying clubfoot, and we were teaching midwives how to do it and not teaching them how to pick up all the other obvious birth defects. And this was wrong. I had plastic surgeon colleagues sort of trying to do the same thing with cleft lip and palate. So I think the first stage is to teach birthing attendants to at least identify the structural birth defects. And you've already mentioned anorectal malformations. Many of those should be identifiable at birth if they were taught how to look for them, and I think that the dilemma I want to bring up, counter-arguing my talk, clubfoot is the low-hanging fruit. We were able to treat this with a non-surgical, minimal surgical technique, a tenotomy. And we could task shift it to non-specialists. You can't do that with Hirschsprung's disease or gastroschisis. And I think in general surgery, general pediatric surgery, you have life-threatening conditions that have to be treated now. So I do think to translate what we've learned in clubfoot into structural birth defects, I would love to see this happen. But now we're dealing almost universally with actually very complex surgical corrections. And so you have to have the referral pathways, I think, the early identification referral pathways. This idea of taking it right into the community and training someone who's not a specialist to do it would be very difficult with most of the other structural birth defects. Now you're also talking then about all of the other genetic disorders that we see, the genetic deletion syndromes and so on, that are not easy to identify at birth, but become evident early on. And that's where the RBSK program in India has both birth defect surveillance, which is on structural birth defects, but then also early intervention for developmental delays of various kinds, which would come through the system and eventually be diagnosed with, you know, a genetic deletion disorder, for instance.
Thanks.
That's getting very complex, I must say.
Yeah. Before carrying on with this question, I'd like to ask a question to Tijil, that, you know, having a birth defect, what motivated you, or how would you motivate people with defects to say you can do it? Because, you know, you are a very established racing car driver. Could you say something to the public as to how you did it and how would you motivate people?
So yeah, when we basically racing, like, so it's a very physical sport, and it was very physically demanding. But I think as a motivation, and my only goal was to always keep moving forward and always have the will to win. Although we had other drivers who are fitter than me, bigger than me, and also older than me, stronger in every way. But I think the main motivation was, you know, just to do it for yourself and also for your parents, and also, I mean, just provide another challenge. It wasn't anything that was holding me back, luckily, because I've had 2 successful surgeries, and yeah, I think that just helped a lot. And yeah, as a motivator, I would just say, guys, you just can't give up, and you just have to keep trying, and then we'll all make it there one day.
Thank you very much. The question I was going to ask the panel is that somebody on the question and answer panel asked about checklist. And I was going to mention this, that I think Tanzania has a checklist. Will that be an option for the midwife level, that if they have a checklist to say, you know, look at the genitalia, if there's an opening there for anorectal malformation, or is this baby just bringing up green stuff, vomiting green stuff, that needs to be attended to? What does the IBCD group feel about developing a checklist, or if there's one, where is it? Salimah? Yeah.
Kokila, there is actually on WHO's website, there is a manual for birth defect surveillance. And I think there is also a handbook, which includes a lot of structural birth defects that can be identified. So I welcome our colleagues to go to WHO's website and look for these handbooks. There are also mobile apps with birth defects, pictures, and resources for identification. The other thing I wanted to say to your previous question is that integrating surveillance and care programs is very essential. WHO and CDC have been promoting birth defect surveillance in many countries, and I have been involved in some of these surveillance development work. The problem is that surveillance works at universities, away from the care programs. And sometimes even when they identify through surveillance, good surveillance programs, any birth conditions, they don't know that care programs exist not too far from them. So any linkages between surveillance and care is also very, very important.
Thank you very much. Do any of the panelists want to add to this?
I think in most of the medical colleges, they do have a very long checklist, because when I went and looked at our rural hospital the birth defects that they have identified, I see one 2-page long list which they actually fill, and they check everything and fill it. So I think it may already be part of the curriculum in many places. And in India, especially, as I presented in the first GICS, they had these ASHA workers who work at the local community level, and they have a very extensive checklist of not just checking at birth, but they check periodically at different ages. The checks are there in the community at different ages where everybody is actually checked at more than one instance.
Vrisha, if you could put the ASHA program's website or something on the chat for people to go there, because that's an excellent program. Yeah. Where besides they were brought in and trained during the polio crisis, but they've actually been very, very useful for healthcare throughout India for other conditions and other diseases. So that will be very helpful. One of the other questions that I did have is that, you know, in this kind of work, we talk about task sharing and but working together as a team with all health professionals to bring about changes. But what is happening is that the clinical officers and the medically qualified doctors, there's beginning to, tensions are beginning to develop in certain countries where the task sharing program has been very successful and the medical fraternity is feeling out of their depth now. And how do we manage this? Because we need both. And how can we create that collaboration and avoid a resistance, which is bad for healthcare? Salimah, do you want to start? You kind of, because that is a problem. And I would want every panelist to say something about this, because if it does become a war between different health professionals, who ultimately suffers is the patient. And that's, we're going too many years back. We'll be going centuries back if we go down that route.
But this question is also a very centuries old question about nurses and doctors and field health workers not working together, and this idea of territorialism, where this is my work. I recently actually saw this in action in Pakistan. You know, we went with MiracleFeet into Pakistan recently, launching our program there. And there are surgeons who really believe that this clubfoot treatment can only be done by surgeons. Even the Ponseti method, they just believe that. I honestly don't have the answers. I think, you know, starting with the curricula at medical college, nursing schools, and other professionals, I think there needs to be more integration at university levels. We have very siloed programs where people don't see the value of other professions adding to the patient care or prevention programs. I think the advocacy and working together in groups like this, like GICS, for example, is a clear example. I've attended GICS membership meetings, and you have members from all professions, which is also a model to do this right. But it's going to take a long time. I don't think we can have a solution very soon.
Vrisha, do you have a comment on?
Sorry, I was typing. Could I just repeat? I'm sorry, I didn't hear it. I was typing out the.
Okay.
I was typing the NHM.
The rift between healthcare professionals and physicians, where where they are very well established programs by healthcare professionals, and clinical officers. And that seems to be in competition with doctors. Some doctors believe that, and the other way around, where there's more authority needed by some of the clinical officers. So how do we manage that?
Yeah, okay. I think we have seen some of that when we were trying to do our district hospital training program, where we were trying to train the people to do surgeries, which some surgeons feel is that they should be doing it. I think that the thing is to avoid this kind of a confrontation is to start off, and they're not in the big cities. So when you are putting your training programs and the trainers, you need to make sure that you start off in the peripheral areas where these facilities are not available. And in that case, they are not threatened. And I think the only other way is to educate them and to get them into the system itself. So the people who feel threatened are actually forced to become trainers. I don't know whether that will work very well, but I think that is only other thing that could be tried. But it is a problem when they feel that their livelihood is being threatened, because they are the ones who should be operating, and then we are teaching somebody like a district hospital surgeon to operate what they should be doing. So it causes a bit of a problem. I think it has to be handled with a lot of sensitivity there.
Norgrove?
That's an interesting question, and it's human nature, isn't it? And Vrisha mentioned income in that, and I'm appalled that it gets to those kinds of discussions, but it does. And surgeons who clung to doing surgery because it paid them money as compared to doing a Ponseti technique because it didn't. This is a real corruption, actually, of the ethics of medicine. It takes a champion, firstly, somebody who is a champion and knows how to collaborate and is well known for this. And I think as we've seen that we can task shift to non-specialists in clubfoot care, we've seen in the UK, in Canada, physiotherapy run clinics where they're doing the casting. But all of this has to be, I think, under the authority of the orthopedic department. You need that authority structure. You need that it is still within the specialty of pediatric orthopedics, and that there's this collaborative approach in order to distribute the care. I'm seeing now something else happening, and that is certainly in Canada, let's say, where we're getting the physiotherapy-led clinics. The surgeons are no longer putting their hands on those little club feet. They're not doing the manipulations. They're doing the surgeries that are necessary. And I think you really lose that sense of why we do it. So there's a real balance that has to be achieved here. And it takes, I think, putting the money issues aside, if you can, a champion who's well known in the country as a specialist, an orthopedic specialist, that says, I endorse this. And it's always going to be a delicate balance, a really delicate balance. We just have to keep doing what we believe is ethical care and put the money, that the doctor earning an income, out of the equation. And that's where it works actually quite well in the public systems. I've seen in India much better clubfoot care, I have to be a bit controversial, in the national public hospitals than I have seen in the private hospitals. The private hospitals, you know, I've seen patients from the private hospitals going to the public in order to get better clubfoot care, because the money issue is taken out of the equation then.
Thanks, Norgrove. I'm going to put the same question to Tijil. As a person with clubfoot problems, you know, in your racing team, it's a very competitive sport, and it can be, there are a lot of kind of strong personalities in your sports. How did you manage this kind of, if I can use the word, discrimination of somebody who's young, somebody with a deformity? How did you manage that within your sports? Because it's the similar thing, but in a different environment.
Yeah, so basically, I've been in a very, I would just say a luckier sport where the discrimination is quite low compared to other sports, hopefully. And also I've had really, really good understanding, and you know, my parents have been very supportive of the whole thing, especially. If there's any kind of, I lack motivation or ever I doubted myself, my parents especially have been very, very supportive, and they have helped me through everything. And they've also made sure that I never felt like a disabled child or a child who had a condition. So I think the credit just goes purely to them on that side. And in the sport wise, yeah, I think compared to others, I've had to face a little bit more of a physical challenge compared to them. But the only way I overcame them is just to clear my mind off all of that and just like focus and then get to the gym, work harder, and also, you know, while taking care of my leg and, you know, making sure I don't overstress all of these things. Because as a racing driver, it's actually extremely physical. We lose about 4 to 5 kilos every race weekend. And yeah, like you get bruises, and you know, it's part of the sport, and accidents and all these things keep happening. So yeah, mentally I just had to get stronger and stronger. And yeah, I think the condition, luckily for me, hasn't been that big of a setback. Just taken it as another challenge, and then especially my parents. I'm extremely grateful to them to be giving me that opportunity, and also they have made me extremely strong in the way they have built me. They never made me ever feel like I was ever and I've done all kinds of sports thanks to my parents. Even though I used to be, having this condition, my parents used to let me go live like a normal child, play my regular football, run around, play cricket, athletics. I've tried all kinds of things, but somehow my mind always stuck to racing, and yeah, that's how it's always been. So yeah, I think especially the parental support is one of the main things that's supposed to be there, and just motivating yourself and being strong in the head and mentally. You have to be extremely strong and motivated to whatever you want in life. Just don't take any of this as a setback, and then just moving forward. And yeah, I think that's what keeps you going. And I think if I can make it, and everyone, I hope everybody else I can also make it. I'm pretty sure anyone born with clubfoot in this world can do wonders. And yeah, I think that's very important that everybody keeps their head straight and calm, and okay, and never ever doubt themselves, and always just focus into the future and always work hard towards their dreams, and it'll all come true.
Thank you very much, Tijil. I think we've reached just 2 minutes beyond the 4:30 mark. So thanks to all the panelists for excellent talks and also answers to the questions people had. To the administrator of this meeting, there are a few questions that we couldn't put out there. It's like a reference to Paho's Clubfoot course. If we can give them some of the information, so if they could just go through the questions and give people the answers to some of the links to some of those.
Kokila, yes, we can. We'll be able to have all the questions that have been answered, and we'll be able to get answers to those and add them to the presentation after.
And
Okay.
I request that you can share our email addresses with the participants if they want to reach out to us directly with any questions.
I'll make a note of that. And I know
Thank
there
you.
was also a question about if the presentations would be available. So we will confirm with all of the presenters if they're feeling comfortable with sharing their slides. So we'll include that if anyone is comfortable with that.
Okay. What I'm going to do at this stage is just hand back over to Tahmina if there are any more questions people have in terms of sharing emails. And so I need to chair another meeting, so I'm going to leave. But a real thank you to all of you for giving me the opportunity to run the question and answer session.
Thank you, Kokila.
Thank you, Kokila. And I don't think we have covered everything. We can continue for hours, I know, but everybody has other commitments. So maybe we'll finish it here. Thank you so much, all the panelists, Judith, Tijil, Penny, Vrisha, and Salimah, for giving a wonderful presentations and insights into the clubfoot care in LMICs. I'm sure all of us has been benefited by these, and hopefully we will be able to work together to make it better for the children with birth defects. Thank you very much, and thanks to Maggie, Jenny, and Eileen for the technical help they have provided. Thank you very much. Thank you.
Thank you, GICS, for organizing this webinar.
Thank you very
and
much.
inviting us. Thank you.
Bye-bye, everyone.
Bye.
Bye.
Thank you.
Bye.
Thank you, Madeline.
Bye-bye.
Bye.